Hello, my name is Alan Shim, and I am the Director of Ultrasound for the EM department at Allview UCLA, as well as Director of Ultrasound Education for the David Geffen School of Medicine. I'm going to give you a talk on cardiac hemodynamics and really highlight the concepts behind all of the equations and measurements you may have been exposed to. My first experience with echo really began in residency and has been paved with excellent mentorship all along the way. I first saw a D sign in the patient with suspected massive PE in the ICU, and no one did POCUS back then, so it was really the cardiology fellow who came in to do the echo and who taught me about the D sign. Later, I was the first EM resident to do an echo elective, and I felt like a foreign exchange student sometimes. You know, the weird kid who doesn't really speak your language. But the cardiology division was completely welcoming. I'd sit down and read with the fellows as well as the attendings. And in ultrasound fellowship, I continued to learn echo, and when I joined UCLA in 2012, I approached the cardiology chief, Robin Waxner, and she really had understood the advantage of POCUS, and when I told her I wanted to take the National Board of Echo exam, she really didn't balk. She didn't think that was far-fetched at all. She was completely supportive. It was about 3 months of painful studying. I mean, just like hours of reviews and doing questions. But miraculously, I passed, and since then, I've been able to use my training to teach my fellows, residents, as well as students. Now, there were so many equations and so many topics that were not pertinent to EM, and probably most of medicine outside of cardiology. So I just kind of crammed as much as I could for the exam, and when I was done, most of it went out the other end, kind of like your first pass metabolism right here. But over the years of having to teach this effectively, I developed a second pass understanding, if you will, which I hope to share with you in this talk. Really, it's learning the concepts first. And the first concept is that the heart is very much like a worm. See how there are like segments or chambers in the forward motion of the worm? And it's all coordinated by the contraction of muscles in the various segments, similar to the movement of blood in the heart. So for example, in systole, we know that the mitral and tricuspid valves are closed, and there is ventricular contraction leading to blood going into the systemic and pulmonary circulations. In diastole, we know that the aortic and pulmonic valves are closed, and there is ventricular filling. Understanding which valves open or close and what phase of the cardiac cycle is an important first step in understanding how we can use different measurements. For example, when you're measuring LV stroke volume, you wouldn't measure it in diastole, but in systole. And you wouldn't measure it over the mitral valve, but in the LVOT or the aortic valve. So I'm a hobby woodworker, and I learned mainly through my high school woodworking classes, as well as through YouTube videos. Really, really great resource. What I really realized early on is that there are many ways to do something, and you can build devices like crosscut sled or a router table, and these are called jigs, and they help you to make your work easier. This is the same in advanced echo. There are often many ways to measure the same pathology, and rather than try to remember all of them, it's much better to understand the purpose and the basic foundation behind them. And with that, you need to know two foundational equations for echo. The first is the Bernoulli equation, which is important in assessing pressure gradients or pressure difference between two adjoining chambers. And the second is the continuity equation, which is critical to understanding valvular pathology. First, mass has to be conserved. You can't make a volume of blood disappear or disapparate as in Harry Potter. When you squeeze a chamber, the blood has to move somewhere else, like this little squishy chick right here. Next, let's talk about pressure gradients. When you have two adjoining chambers and if blood flow is going from right to left, if there's regurgitation of flow, as seen with the red triangle, we know that the pressure in A has to be greater than B. And this pressure difference is directly related to the degree of regurgitant flow. The pressure in A has to be this pressure gradient plus the pressure of B. Why? Just imagine if you were being asked the height of Kubert, who's this kind of orange, perpetually confused guy right here. You wouldn't say that it's just the height of the block that he's standing on, which is basically the pressure gradient between the block below and the block above, but it would also be the height of the blocks before this block right here. So that's the static pressure. So this is why pressure A has to be the pressure gradient plus whatever pressure is in B. So how do we convert regurgitant flow to a pressure gradient? This is all due to Daniel Bernoulli, who was a mathematician as well as a doctor over 300 years ago. He was the first to actually invasively measure blood pressure, kind of a predecessor to the A-lines that we use today. But he did this by recognizing that potential energy and kinetic energy are inversely related. With loss of height, you have an increase in kinetic energy and vice versa. Specifically, he was able to show that the pressure in one chamber was equal to the baseline pressure, the kinetic energy or dynamic pressure, and the potential energy, and that they have to be equal across two adjoining chambers. In cardiac physiology, we don't need potential energy because the heart chambers are roughly equal in height. So we take out this term, leaving pressure being equal to the static pressure plus the contribution from the kinetic energy or dynamic pressure. And this is actually half the density of the fluid times the velocity squared, which is right here. And this is, if you remember from physics, this is similar to the force calculation for kinetic energy, or half mv squared, with m being mass. But remember that because we're talking about pressure, we know that pressure is force divided by area. This is why we use density and not mass of the fluid. And many of you may recognize that this is the modified Bernoulli equation that we use in echo. In order to get that, we actually take the density of blood, which is right here about 8, we multiply by half, and this is where we get our 4 mv squared. A classic application is the calculation of right ventricular or pulmonary artery systolic pressures. We use the tricuspid regurgitation jet velocity for the 4v squared calculation, and this gives us the pressure gradient between the right atrium and the right ventricle. And in order to get the right ventricular pressure, we need to add that with the right atrial pressure. And this we get from our IVC variability and maximal diameter measurements. Let's now talk about the related continuity equation. This basically says that the volume of blood has to be preserved between two adjoining chambers. Volume is calculated as the cross-sectional area, or CSA, multiplied by the sum of all velocities going through, or the velocity time integral, or time velocity, or VTI, or TVI. And going from one chamber to the next, the cross-sectional area may be bigger, as in this case, but then the velocity has to slow down. If the next chamber is smaller, then that volume of blood has to accelerate. In terms of valvular regurgitation, we need to figure out the effective regurgitant orifice area, or EROA. This is essentially the size of the hole in the valve. We often can't directly measure it, but we can use the continuity equation to estimate the EROA. An example of this application is the proximal isovelocity surface area method, or PISA. Now, this pizza might be hard to swallow, pun intended, but if you think about flow going down a drain, you'll notice that the water actually starts to kind of accelerate, and at a given distance from the drain or radius, the velocities of the water actually normalize. They actually become uniform. And this regurgitant area or kind of shell right here, because we know the uniform velocity through color Doppler and the radius of the shell, we're able to get this first initial chamber. And we know that from the continuity equation, this initial chamber has to equal this second chamber, and we're looking at this EROA right here. So in order to solve for this EROA, we have this regurgitant jet here. So by plugging in the continuity equation of area times velocity equals area times velocity of the second chamber, we're able to use this velocity of the second chamber, this area and velocity of the first chamber as measured by PISA, and we're able to get the EROA, or this effective regurgitant orifice area. Really cool, huh? Another use of the continuity equation is by looking at the volume of blood entering and leaving the left ventricle. Normally, this stroke volume entering the LV in diastole is calculated by the diameter of the mitral valve annulus and diastolic inflow. It has to be equal to the same volume leaving the LVOT, which is basically the LVOT area multiplied by the LVOT VTI. Now, when you have regurgitation, that's not the case. However, we know that what enters the left ventricle during diastole has to equal what comes out. So in other words, what enters the left ventricle, this mitral valve stroke volume, has to be equal to the sum of the LVOT stroke volume plus mitral regurgitant volume. And we can, basically do a little geometry, a little algebra, and we can solve for this MR volume by subtracting the LVOT stroke volume from the inflow volume. I want to take a step back and say that I'm giving this talk on hemodynamics to a non-cardiology audience in 2022 because of support of mentors along the way, and by this increasing recognition that this advanced skill at the bedside is becoming increasingly relevant to your practice as intensivists and my practice as an emergency physician. But in order to build these skills, we need to start our POCUS training early, and we need all specialties involved in training. As Director of Ultrasound Education, we start our students really early. These are first-year students that are learning POCUS during their second week of medical school. We're not teaching them equations or advanced anatomy, but rather just the love of POCUS, the ability to visualize dynamic anatomy. We had a competition at the end, and one skill was just to demonstrate internal jugular diameter change or pulsation via breathing. One group, without even knowing what a passive leg raise was, just discovered this on their own. You could see that they're lifting the student's legs while imaging his IJ. And I put this slide in my talk as a reminder that an important part of our daily work, in addition to patient care, is to really help inspire and teach future generations of physicians so that they aim higher and that they're better than us. Okay, now let's talk about the concepts of hemodynamics in valvular stenosis. So in terms of mitral stenosis, as you may know, it comes in two general flavors. There's mitral stenosis due to rheumatic heart disease, which generally affects the leaflet tips before it affects the annulus right here. And oftentimes you'll see this doming right here, this like hockey stick appearance of the anterior mitral valve leaflet. And then we have calcific mitral stenosis, which is typically in the elderly, and we see that it involves the annulus first before it involves the leaflet tips. In terms of stenosis, just as we're concerned about the EROA in regurgitation, here we're actually concerned about the cross-sectional valve area when it's opening. And one way to measure that is just actually by directly visualizing it on a parasternal short axis and trying to measure this area right here. But there are some major limitations to that. For one, if you actually have a lot of calcifications, remember that there's a lot of shadowing, so you're not really able to image the entire borders very well. Second, depending on which short axis plane you're in, you might actually overestimate this valve area. So for instance, if we're trying to measure this area right here, but unintentionally our parasternal short axis gets this plane right here, we would be overestimating this valve area. So what can you do? The first thing you can do is just to estimate the mean pressure gradient in mitral stenosis between the left atrium and the left ventricle. And so this is basically the VTI of the diastolic inflow, which includes both the E wave right here and the A wave. And if you get a pressure gradient that's greater than 10 millimeters of mercury, this is suggestive of severe MS. Now we can also use the continuity equation, and again, the principle is that what comes into the left ventricle has to equal what goes out of the left ventricle. And so the mitral valve area, which is what we're looking for, multiplied by the mitral valve VTI or TVI, which is that diastolic measurement that we just saw in the last slide, has to equal to the LVOT diameter multiplied by the LVOT velocity time integral or time velocity integral. And so knowing the three terms, we can solve for this mitral valve area. Pressure half-time is a related concept. The lungs and airway is the first chamber, and the opening of the mouth is actually the orifice for the second chamber. And so if you want it to blow fast, you actually have to pucker your lips. But what happens then is that there's a higher pressure in the lungs and airway, and it takes longer for that pressure to equilibrate with the outside pressure. For example, this big bad wolf will take longer to blow the piggy's house down than Michael here because his mouth is wider and open, whereas this big bad wolf has a tighter pursed mouth right here. And this is really what is happening with mitral stenosis. The smaller the valve area, the smaller the orifice, the longer the pressure half-time. And we calculate this by using the E wave right here. We go from the peak to basically its baseline right here. And the pressure half-time is essentially the time between the maximum peak pressure and about the half right here. And if you use this equation, you get the mitral valve area, 220 divided by pressure half-time. The greater pressure at halftime, the smaller the valve area. Another thing that's happening in mitral stenosis is that we know that there's elevated left atrial pressures, right? Because there's mitral stenosis right here. So those left atrial pressures are going to backfeed into the pulmonary circulation so that you'll get things like pulmonary congestion, but then you also have right-sided pressures. This is why you want to measure the RVSP. Remember that you can measure the TR jet in apical windows like here, as well as an RV inflow window, which is achieved just by fanning inferiorly from a parasternal long axis window or from a parasternal short axis window at the base. If you get an RVSP that's greater than 50, that is associated with severe MS. Now let's talk about aortic stenosis. We already know from the continuity equation that the degree of flow acceleration is inversely related to the orifice area. So using continuous wave Doppler through the aortic valve on apical windows gives you the systolic envelope here. Calculating this maximal velocity at the peak and using the 4V squared, we have the pressure gradient between the systemic circulation as well as the left ventricle. And in general, a Vmax that is greater than 4 meters per second or 400 centimeters per second is indicative of severe aortic stenosis. Now, what about artificial valves? Due to their variable shape and materials, they're often difficult to interpret or image. And this is why we have to consider a different ratio, and this is called the dimensionless index. And what that is it's basically the LVOT VTI over the aortic valve VTI. The concept behind this ratio is a little bit difficult to grasp. What we do know is that if the prosthetic is working correctly, we should experience a smaller acceleration of flow through its valve area. And so that will be reflected as a smaller AV-VTI, the red peak. And so if you're comparing the LVOT VTI to the aortic valve VTI, you should expect a number closer to 1 if it's normal. Now, if that prosthetic becomes progressively more stenotic and starts to malfunction, what you're going to see is that AV-VTI will experience acceleration and you'll have a taller red peak. And if that ratio is less than 50%, there is at least mild stenosis. And anything less than 25% suggests severe stenosis of that prosthetic. In a prosthetic AV valve, you measure the LVOT VTI by using pulse wave Doppler, and this is because you just want to sample just before the aortic valve itself, which you can do with pulse wave Doppler. Now, to get the VTI post-aortic valve, you will use continuous wave Doppler, and remember that with CWD, you're not really measuring a specific volume of blood, as in pulse wave Doppler, but actually all the blood that's traveling along this line right here. So you're able to measure all velocities of blood traveling in this line, but you can't tell which velocities correspond with which position along the line. This range ambiguity is not important because we know that with stenosis, it is the acceleration of flow through the stenotic valve that has the greatest velocities. And that's why we can use the envelope attained on CWD as a aortic or post-aortic valve VTI. I want to give you a quick table summary of the criteria that we've discussed so far. I don't want you to memorize any of these numbers because you can find them usually online anywhere. But just to get an idea of the concepts behind the commonly used criteria for severe stenosis. So what we do as physicians is amazing. We often bring our patients back from the verge of death. However, we often do too much between clinical care, teaching, and administrative duties. This is a reminder to get your exercise in. For me, if I don't swim after a few days, I really feel cranky. And so it's really important to take care of yourself because really you can't take care of others unless you focus on yourself first. Okay, now we're at the home stretch. Let's talk briefly about the Venturi effect and how that is related to the Bernoulli equation as well as the continuity equation. First, we know that flow has to accelerate when moving into a smaller orifice, as described by the continuity equation. Second, we know from the Bernoulli equation that the sum of all three terms in one chamber, the static pressure, right here, the kinetic pressure or dynamic pressure, and the potential energy or pressure, that has to be equal to the three terms in the adjoining chamber here. So we know that the acceleration of flow leads to an increase in kinetic energy in this latter chamber, but at the expense of reduced static pressure as seen right here. In a nutshell, the Venturi effect says that pressure must decrease with acceleration of flow. To illustrate this is an apical 5-chamber window of a patient with hypertrophic obstructive cardiomyopathy, or HOCM. Now you can see that there's mitral regurgitation here, but there's also acceleration of flow as seen by this yellowish green tint on color Doppler. And when you put on pulse wave Doppler, you see evidence of aliasing, with the peaks incompletely visualized right here. For reference, a normal VTI is around 15 to 25 centimeters, and a normal Vmax for the LVOT is usually around 50 centimeters per second or around that range. Now, because you saw aliasing, you wisely switched to continuous wave Doppler, and this is what you see. We see acceleration of flow for sure, and we can see that the Vmax is actually 6 meters per second. Remember that severe AS is a Vmax of 4 or greater. But there's something else that is unusual about the morphology of this LVOT envelope. It's rather asymmetric, and the peak occurs later in systole or to the right. And remember that in traditional aortic stenosis, the envelope is typically symmetric, like here. And this is because the stenotic valve cross-sectional area is the same throughout systole. It doesn't change this cross-sectional area. What happens in HOCM, though, is that you get these late systolic peaks, sometimes called dagger peaks, and that's because the stenotic area actually does change and it worsens with systole. In this case, it's not the valve causing obstruction, but the distance between that septum and the anterior mitral valve leaflet. So in early systole, as seen in A right here, the cross-sectional area is relatively greater, so there's less flow obstruction and there's less acceleration of flow. In late systole, this diameter actually narrows, as seen in the green right here, and so you have flow acceleration, and this is why you get this late systolic peak. So what's causing this? If you said SAM, or systolic anterior motion, you are correct. SAM can be visualized on a parasternal long axis using M mode. You're basically dropping the M mode caliper down about right here, and here you can see that this is during diastole because you could see the E and A waves, and you can also see that this is during systole because you could see contraction of that inferior wall as well as the septal wall right here. But look at what's happening to the closed mitral valve. It looks like it's moving anteriorly towards the septum, and this is the reason behind that dynamic obstruction that we see in HOCM, and why we have to actually increase LV filling by slowing the heart rate down or increasing fluid resuscitation in patients with HOCM. As a comparison, this is a normal M mode where you don't see that systolic anterior motion in systole. So what are the physics behind SAM? Well, it's really the Venturi effect, because there's acceleration of flow through the LVOT. The distal part experiences a reduction in pressure here, and this leads to this anterior lifting of the mitral valve apparatus. And this is the same concept behind lift in an airplane wing. There's increased flow over the top of the wing so that there's a reduction in pressure as compared to under the wing, and as a result, this pressure lifts the wings and the plane, and we have flight. This lifting of the anterior mitral valve apparatus in SAM also causes mitral regurgitation. Notice that the anterior and posterior mitral valve leaflets do not actually come together. They're actually separated right here, and this is the reason behind the mitral regurgitation. What happens, though, is that with MR, you're going to actually have decreased LV volume that's available for ejection out into the LVOT, and this actually worsens that dynamic obstruction. And this is called a V sign because you actually have that regurgitant jet plus the acceleration of flow, so it forms like this horizontal V. This can be illustrated by a man pumping up a tire. The LV is the pump, and the tire is the systemic circulation. There's a pressure gradient between the LV and the systemic circulation as a result of the LVOT obstruction in HOCM, but this is worsened because now you've actually sprung a leak in the pump. This is the effect of the mitral regurgitation. And as a result, you never get the same pressure that you would get without the MR, and this is why patients die or at least have cardiovascular collapse in HOCM. So what LVOT peak gradient is concerning in HOCM? Anything above 30 is concerning for dynamic obstruction, and anything above 50 is concerning for severe HOCM. So I hope you appreciate the concepts of the Bernoulli equation, the continuity equation, and the Venturi effect, and how they are used in advanced cardiac hemodynamics. Please let me know if you have any questions or comments, and thank you again for watching.